Welcome to the second session. It's core topics. I'm Andy Eggleton, and we're very lucky to be chairing today. And we've got three excellent speakers, experts in their fields, to discuss some core topics there. At the end of each talk, once all the three talks are done, we'll bring the speakers up to grab a seat, and you can grill them with your questions there. So do put your questions on Slido, and we'll bring them up. I don't know if this was a deliberate scheduling effort, but immediately following on from our coffee and tasty sweet treats is talk by Dr. Neil Black on update in diabetes in pregnancy. Look at Dr. Black's bio. He is a consultant physician in the Western Trust and the lead for endocrinology and diabetes. He's very busy. He's also the chair of the HSC working group on DKA. And the lead clinician in the Diabetes Managed Network of Western Trust. He knows his stuff. When it comes to diabetes, he knows. On top of that, he's extremely busy with being the Chief Clinical Information Officer for Northern Ireland Electronic Care Record. And as part of the steering group, he's overseeing the move to Encompass. So we're very grateful that he's taken his time out of what must be a hectically busy schedule to come and speak to us today and impart his expertise. So, Neil, thank you very much.
Okay. Thanks very much. You can't talk about diabetes anymore without talking about technology. There is no way. These are now inseparable. All healthcare conditions involve some degree of technology, whether they're pumps, whether they're monitors, devices. And as an anaesthetist, you know this. You've been working with machines that are highly calibrated all your lives throughout your training. But this stuff has now found its way into outpatients. And I want to take you through some of the changes in technology and diabetes that have happened, and specifically patient-facing and patient-held technology, wearables, if you like. Technology today is accessible and convenient. It's connected. It gives access to information, and it gives access to tailored information, and that's whether it's just set up that way as a fixed pattern, or whether that's an intelligent and adjusted algorithm. And artificial intelligence is in all our minds at the moment. The world has completely changed with respect to user-held technology. With smartphones, it's no longer abnormal to be wearing something. Whenever we started with insulin pumps that were non-smart, with fixed ratios, everything was just worn and done, there was a real resistance for people living with diabetes to hand over something on their body, to hand over to something that they did manually themselves, to a piece of technology. And whenever those pumps were changed to become smart pumps that would then be much more flexible and adjustable, the idea that something was controlling their own physiology was unacceptable. But as smartphones came in, it's completely changed the psychology of society completely, and it's made this normal. There is never any argument about wearables these days. I'm going to talk about glucose, connected pens. I'm going to talk about pumps. And then we'll perhaps discuss or think about the implications of that for your obstetric practice. Because wearables mean they come in and there's a thing that you don't recognize, you don't understand, or you don't know. But necessarily, I'm going to make that a little bit broader. And I'm going to talk about the broader use of technology in diabetes. Gone are the days when it's a simple finger prick. People wear a 50p sized device on their arm. They may lift up their phone and take data from that. I've had to stop asking patients to flash whenever I'm in clinic, but this is called flash glucose monitoring or intermittent glucose monitoring. And then there are people who wear continuous glucose devices. Truly gone are the days. And the diary given to our patients to come in is completely gone, but it's there in a different form now. And the main way, and we still rely on capillary or blood glucose in gestational diabetes. An example here are the apps that are available, and the one we're currently using in the Western Trust is GDM Health. This automatically logs a glucose that's taken at that moment through a Bluetooth connection. They can request a callback that's then banked and put into a user interface for healthcare professionals who can then handle that in a scheduled way. So this isn't the nightmare of doctor in your pocket. calling your doctor or diabetes nurse all the time. It's something that comes into a portal that can be handled as part of our work schedule. And they can send messages. You can also add meal details. What did they eat? Was it porridge? Was it cereal? Was it a Danish? Did they have a cup of tea? Whatever. And they can add in what is that in relation to their meal. This is crucial information. This is an example, and inevitably things like this don't project that well. This is an example of a diary of a lady of Indian background who was diagnosed with gestational diabetes 2 months ago. And you can see a couple of things here. You can see a very diligent approach. She's checking as required before and after meals. And there's 2, 4, 6 values, before and after meals, 3 meals a day, nice and regularly spread out. You can see that she's within target beforehand, but after breakfast she's really rising quite a lot. And her diet had quite a lot of free carbohydrate in it, a very strongly based on carbohydrate diet. Within a week, the glucose levels are starting to fall, and you can see a pattern developing. And she's coming really well within target, and she's gone from maybe 60-80% to within target, which doesn't sound so bad, to be honest, up to more like 80-90% in target. And you can see another thing. You can see sporadic deviations out. If you could read that, you could see that she's put down specific dietary information. And this is the thing. Information that would have been held in a diary, which was limited, is now shareable. And not only is it shareable that we can see it, we can see what she's doing and how she's applying her glucose monitoring to her own control of her diabetes during pregnancy. We can also, this feedback to her. It doesn't just feedback information to her, it's feedback's coded information to her. It's feedback when she's out of target. And that's a remarkable positive feedback, the messages we're trying to give. Our conversations now in the Diabetes Antenatal Clinic, bear in mind we see these people every 1 to 2 weeks, or even 2 to 3 weeks, and we're in contact by phone in between those times. So you get to know people really, really well, and they get to know their own bodies really, really well with this feedback. So our messages are getting really strongly reinforced. We can also add in information from the portal about treatment changes so they can track what changes have been made. And we're finding we would always have found that women living with type 1 diabetes, for instance, would modify their own ratios, modify their own treatment, and so on. But now we're finding women with gestational diabetes who've never heard about diabetes before, who perhaps only been dealing with monitoring technology for a matter of weeks, all of a sudden are starting to make their own changes. This is great. This is activating the patient as the person in control. But blood glucose isn't the only thing. That was just the simplest of things to introduce you to the idea of portals. We now monitor glucose using the interstitial glucose. And sensors and meters take glucose readings from different places. Our blood glucose meter clearly comes from capillary blood glucose. And this is very rapidly responsive to arterial and full circulation of glucose within the body. Interstitial glucose is different. This measures glucose from the interstitial compartment. And there's an automatic 5 to 15 minute delay between blood glucose and interstitial glucose, which produces a difficulty in things like exercise or in very rapidly changing glucose. But it's still valuable. And the potential here is that something can sit on the body and continuously monitor that glucose. And this is hugely valuable, and it gives us trends. And you can see in the 2 graphs on the right where you can see what that glucose has been doing right the way through 24 hours. There's potential for information overload here. This is a person living with a monitored device, potentially with real-time reporting, telling them what's happened, minute by minute, even if not hour by hour and day by day. The potential for this for cognitive overload and feeding worry and feeding really that they're doing harm is real. And we've had to deal with that, particularly during pregnancy when people are so well focused into the health of their baby. We have real-time or continuous glucose monitoring and intermittent or flash monitoring. We also have now connected insulin pens. So I didn't want to go this all to be about pumps. I want to tell you about the breadth of things that are available. These are Bluetooth connected pens. If you were to take insulin injections, would you not be interested in what maybe I last did? If something goes wrong, can I remember what I actually gave a while back? And these pens display when the dose was taken and what the dose was. And they connect them by Bluetooth now to different web portals. And that information could be integrated together. This is an example of the LibreView intermittently monitored interstitial glucose monitor, and the kind of thing that comes up on our portal. It's changed the language and outlook of how people view their own data and how we view their own data. Instead of waiting for an HbA1c, which of course during pregnancy isn't really that helpful because of hormonal dilution of physiological changes, HbA1c is not a good guide. It falls on every woman who's pregnant. This gives an integrated view of what is the total amount of glucose readings within the target range. And while outside pregnancy, if you like, what does good look like? Someone who's hitting 70% of their time in range is hitting really, really good control. That's an HbA1c of 7% or 53 millimoles per mole. In pregnancy, we're aiming for 80% or more. And we're aiming for a tighter range. Instead of 3.9 to 10.0, we're aiming for about 3.9 to 7.8. This is really tight. Nobody in this room, whether they have diabetes or not, will ever hold 100% of glucose between 3.9 and 7.8. Particularly if you're a young woman, you'll deviate down even further. The longer we fast, the younger and slimmer we are, the closer that'll come down to even 3. So we'll deviate down below that. And after a meal, you'll peak. I remember exactly where I was and what direction I was pointing in when I was taking part in the driving and diabetes study, and I don't live with diabetes. And I remember seeing my glucose hit 11.1 and thinking, that's a diagnosis of diabetes, and panicking. You check, glucose capillary checks and things, and checking that again. Within 5 minutes, it was down to something like 7. We don't spend 100% of the time in range, whether with diabetes or not, and we shouldn't and can't expect women living with diabetes to either. And that's good because this has changed how we try to communicate this. What does good look like? This is excellent. This is an integrated view. It gives an estimate of the HbA1c, not based on the amount of glycated hemoglobin, but on the basis of the estimated HbA1c from the average glucose and the average glucose itself. It gives the time and range above and below range, a really good snapshot of what we're looking for, as well as variability. What about the daily logs? What does it look like on a day to a person? A person doesn't necessarily see this view initially. What they see is what their glucose is, but it also is predicting whether it's steady, rising rapidly, falling rapidly. So it gives the potential for someone to anticipate what the next change is and react to it. You can see here little green marks, and these are actually little icons for insulin pens. This is a person with a connected pen, and it records underneath what their absolute glucose was and what the dose was, and you can actually see when it was given. And we can start to draw conclusions. If you look at the top graph, there's an early peak. Appreciate you can't see that, but between 6 and 8 o'clock, the glucose starts to rise rapidly, and then there's a dose given. That's very clearly a correction dose. If that person had an early breakfast, that dose was way too late. So we've stopped talking just about ratios and doses, and we're talking much, much more about timings. We find our women have to take insulin not just even before a meal or even 10 or 15 minutes before a meal, but in some cases 20 or 30 minutes, and at extreme times even an hour before they eat. Now imagine that if you had to build that into your day, and you have young children, and you're pregnant, and you have to try to build that in. So the level of dedication these women show to what we have asked them to do is really quite incredible. You can see as it goes down, you can see a lot of variation in the day. This isn't variation in insulin effect. This is variation in lifestyle, in activity, what someone's eating, the different glycemic indexes and contents of what they're eating. But if you look down at the bottom one, see how flat that is. And if you can see the grayed out range, so much more time in range. And this was uploaded only a week or two ago. And within a week, this person had really started to get it from what was fed back and what we'd helped them do to adjust. And you can see days here of relatively flat profiles. Really quite incredible what has been achieved here. And this is a person with type 1 diabetes. But it isn't always rosy, and people don't always get it, if you like. It can be very hard to get across the technical things to someone who perhaps has been doing something a certain way for a long, long time. But there's huge inferences that we can draw, and we can bring something together with us. These aren't just technical tools for gathering information or even for feeding them back. These are empowerment tools. They're educational tools. It's something to help someone understand their own body. And if anyone needs to do that, it's a woman who's bearing a child. It's changed our technology, as I said. The technical speak that we've said has completely changed. But it's also changed the way that we talk in terms of what sounds or does not sound judgmental. We're talking about time and range, not control. We're talking about being higher or lower, not control, not good enough, poor control. This language is virtually gone, and the language of blame is virtually disappearing from diabetes altogether. Let's skip on to that one. So where does the other technology come from? What are the other ways that we can deliver insulin? And insulin pumps have been around for decades now, but insulin smart pumps have only been around for about 10, 15 years in total. These are pumps that can be adjusted. They're not just set by the healthcare professional. They can be adjusted on a day-by-day basis. Whatever ratios, whatever basal rates are there can be adjusted by the person living with diabetes wearing the device for hours on end at a moment's notice. And there are several different available. They're worn, they're connected to an insertion device, connected to the interstitium. And these days, as well, when you join the monitoring technology to them, they may be wearing 2 wearable devices. They can have alarms for high or low glucose. They can have also a low glucose suspend, so when glucose is running low, the pump shuts off its insulin production, and that reduces the severity of the hypoglycemic event and reduces the duration. It also These days, the smart pumps now have predictive glucose alarms. If it looks like it's going low, the pump backs off automatically. An automated safety measure that has reduced and even abolished for some people severe hypoglycemic events. But inevitably, when you give people tools, they will find more ways to use them. And before even healthcare had approved closed-loop devices, third-party open source software or code was being used to integrate monitoring technology and insulin delivery technology. This is truly a transformation in diabetes care, taking away all the arduous work and the worry that these devices can just run. You can go out there and have your Danish. You can go out for a run. You might tell it that I'm about to eat, so it knows, well, you're about to eat. You tend to eat this type of thing at lunchtime. This is the rate that we will start moving at. But the key thing is, whatever it does what you do and we all do in our lives. As it starts to do something, it monitors the response, and it adjusts it again on a continuously monitored basis. There actually are 3 commercially available hybrid loops now. And the one with good UK approval is CAM-APS, which is ever-increasing trial data showing incredible improvements in control. There's Tandem Slim, and then there's the Medtronic systems. The key difficulty for us is that the monitoring technology isn't funded in Northern Ireland. We have the interstitial glucose monitors, and we actually have continuous glucose monitors for type 1 in pregnancy, but outside pregnancy we don't. There's huge potential for this to take away a lot of the pain of managing diabetes in pregnancy. Main barriers to us are access to pumps and funded healthcare that's available to get people upskilled and ready to take them on. Access to CGMS, which isn't funded and now it's outside pregnancy. Confidence with the do-it-yourself automated pancreas systems with the third-party algorithms. And that's both with the person with diabetes, but also the healthcare professionals. We do not trust this wildcat stuff that people are doing. They thought that someone coming in to your operation theatre was something that they got off the internet that controls everything. I mean, seriously? But yet it works, and it works really well. What can it do for me? Intermittent glucose monitoring, continuous glucose monitoring, connected insulin, pens, connected pumps, and clinician portals. Glucose monitoring is now continuous, painless. There are alarms that anticipate. It provides analysis and codes the information. Is this in range? Is this out of range? Is it going down? Is it going up? And sharing. Memory, it retains the information so that it can be looked back on, reflected upon, learned from. It can give dose advice, and it can actually automate those doses. It gives immediate and retrospective knowledge of the person's glucose to them and records the doses of insulin that they've given and allows sharing of that information. This is true. I mean, I watch all these things and I love this stuff. The world has changed. It's there. And it's changing right under our feet. And there's no separation now between our personal lives and how we appreciate technology and the effect that's having on the people that we look after. Because they're exactly the same as us. Everything is changing. And I think technology really in diabetes is now living at a gallop. It's not changing. It's changing faster than the healthcare service can keep up with. This has implications for obstetric anaesthetists. There's no doubt. Any wearable technology is a potential threat to your control over what's happening in very controlled scenarios. Patients that are more empowered and more motivated and more informed about their diabetes are a potential threat to the very controlled environment that we try to keep during an anaesthetic scenario. No matter what happens, the diabetes team that's looking after these people and helping advise them should be given a care plan for the people that come into your operating theatre. A care plan for what will happen beforehand, whether they're in labour or preparing for surgery and fasting, or what's going to happen during it or after it. Really wearable devices that need any manual input really can only stay active and be the primary method of monitoring or controlling that person's glucose if the person continues to be competent and capable of exercising that competence to do something about it. And our standard approach is if that person and their significant other with them can be there through the delivery and can keep control of that and address all those things for you, that's fine. But that is the exception. Largely speaking, we still revert over traditional methods of blood glucose monitoring because it is a quicker response. You can check as often as you want. With blood glucose monitoring, if something is changing, you know that what the reading you have from the blood glucose is what it is now, rather than from an interstitial monitor. But we will see the interstitial monitors come in as part of obstetric anaesthesia, I think, because these monitor trends. Are we within target? Are we staying within target? Do we have the cognitive bandwidth, any human being in your theatre, to watch everything every 5 minutes? Maybe not necessarily. And in fact, maybe these are well tailored to become part of our monitoring tools. Largely speaking, we switch over to intravenous insulin as well as blood glucose monitoring with the various fasting perioperative protocols that we have. This doesn't take away from that, but it can be a piece of communication, let's say, and engagement for the diabetes team to have forewarned the person living with diabetes that this will have to be taken control of. To be honest, a lot of women are quite happy for that to happen. Through the fury of a normal delivery, for the time whenever someone's sedated or rather not able to view what's happening, the potential for their consciousness to be reduced because of an emergency, we have to have backups that are controllable by healthcare staff. So don't panic. The people who are wearing these things, they should already be forewarned that we may have to take over. In fact, that can be a piece of comfort to the person with diabetes, and it isn't a threat to them. When they take over, we have tried and tested protocols that will still work, our traditional protocols. Respect the autonomy of the person. Learn from them. Listen to them. Acknowledge their fears, and we can reassure them. They know that you're on their side, but the team should have already have laid the way for you. Okay, that's me.
Thank you, Dr. Black. That was very informative. Something that's sort of a field that's always constantly changing. So just a reminder, anybody have any questions for Dr. Black, just to put them on the Slido, and we'll address them all at the end. So it's my pleasure to introduce Dr. Paul Brennan up to the stand here. So Dr. Brennan is an adult congenital disease consultant specialist in the Royal. He's a fellowship in the Bristol Heart Institution. He's a specialist in adult congenital heart disease imaging and structural heart disease interventional imaging. He's a research MD in cyanotic heart disease, and as if that's all not enough, with full admiration, he's a really keen ultra runner. Very good. Welcome to the stand. Thank you.
Thanks very much for the opportunity to speak today. A few more slides in my talk, but thankfully I'm much less impressive than Neil, and my introduction was shorter. So I'm going to talk, it's a very broad overview of cardiovascular disease in pregnancy. You all know that acute cardiovascular emergencies in pregnancy can be scary and it's very traumatic for staff, traumatic for the parents, and obviously very risky for the baby. So it's really a broad overview of things today. I have no disclosures again because I know it's important, isn't it? But very little to disclose. Overview of my talk, I'll talk briefly about the physiology of pregnancy. Now, I'm not really continually self-deprecating, but you guys are anesthetic specialists. You know a lot more about that than I do. We'll talk a little bit about the epidemiology of cardiovascular disease, mainly non-hypertensive cardiovascular disease in pregnancy, and then finally about some specific patients. Just as a reminder, these are our classes and levels of recommendation and evidence. So if I refer to a treatment or something, it's based on this. We're class 1, generally means the intervention does good. Class 2 is a bit ambiguous, and class 3 is where this intervention is not recommended. So we all know this, we're taught this at medical school, but we know that throughout the trimesters, cardiovascular output, so cardiac output, circulating blood volume, stroke volume, all tend to go up. This is offset against pulmonary vascular resistance coming down. And when you think about all of that, then it can help explain why certain cardiac phenotypes and conditions struggle with pregnancy and why they struggle at certain stages of pregnancy. In particular, this slide, I think, really nails it and shows the big risk for the majority of our patients. The majority of our patients, it's around the time of labour and thereafter. Actually, if you think of an aortopathy, you're running a nice low systemic vascular resistance throughout pregnancy, and then by at the end you have pain, you have effort, you have increased systemic vascular resistance, and this is when you're at your risk of dissection. For example, the same applies to cardiomyopathies, whereby the patient's put under extreme strain at the end. And that's why the most important aspect of management of this patient group is us all coming together as a group and formulating that delivery plan very early on. We know that maternal morbidity complicates complicated pregnancy, in up to 4% of cases. Why is that? Well, women are now having their first child at older ages and subsequent children at older ages. But also, if we look at congenital heart disease in particular, as I say, I'm not talking about hypertensive cardiovascular disease today, we're talking about congenital heart disease today as part of this talk. Our surgeons, our paediatricians have just changed and revolutionised the management of paediatric conditions, and now over 90% of patients with congenital heart disease are living to childbearing age, and that carries massive implications. So we're therefore seeing a natural increase. The Amsterdam group, led by Julian Rose Hesselink, set up the ROPAC registry. This is a really accessible registry online. 60 countries worldwide participating in this, collecting demographics on cardiovascular disease and pregnancy, outcomes, pathologies, and this is a really, really elegant piece of work that's been done. In terms of their data, well, you can see here that once you take hypertensive disease of pregnancy out of the equation, congenital heart disease represents the majority of the cardiovascular disease seen in pregnancy, followed by valvular heart disease, cardiomyopathy, and then more rare, but highest risk would be your aortopathies and your pulmonary hypertensive disease. It's a massive registry with some lovely data. If you then look at, what these broad categories, how do they do in pregnancy, you can clearly see, and I know this may not project very well, but this is a lovely graph that shows in red maternal mortality, blue heart failure, and then in green arrhythmia. And the one overwhelming thing that you can see, understandably, is that cardiomyopathy is associated with a high incidence of heart failure during pregnancy, but the pulmonary hypertensive disease is associated with significantly increased mortality and heart failure. And for that reason, as I'll allude to later on when I talk about the risk categories, it is totally advised against that these patients become pregnant. So these physiological changes are undoubtedly what leads to this, and it's a mixed bag of the picture, really. If you think of a pulmonary hypertensive patient, why do they struggle in pregnancy? Well, they already have a pulmonary vasculopathy. A lot of the medications are contraindicated and often get pulled back at the start of pregnancy, and then you have these late changes physiologically which stress the body. So it's a really, really nasty pathology. I worked in Bristol Heart Institute predominantly as a ACHD fellow, and then I've come back. But Bristol Heart is one of the leading maternity obstetric cardiology units in the UK, and I did the clinic there and covered all of the inpatients. And we always had the approach, well, it's a balance, isn't it? It's maternal and obstetric balance. You're trying to make a decision based on what is safest for mum and what is safest for baby, and then coming somewhere in the middle. The European Society of Cardiology have a very elegant guideline that was published in 2018. Again, it's free, it's readily accessible, and they talk about different pathologies that you could possibly encounter in pregnancy. And then they risk stratify those patients into 5 groups, and that's your modified World Health Organization. And that's based on significant number of registry data that's been put together. So the group 1 patient is your simple lesion. You'll see a lot of this is congenital, small ductus arteriosus, pulmonary stenosis, mitral valve prolapse, and repaired simple defects. These patients are very low risk. They can be delivered locally. They can be seen as a local patient or without cardiovascular disease should be. They do not need to come to a tertiary centre to be seen at the expert obstetric clinic. Now, they may still do. And that's fine. But the recommendation is here. As you ascend, though, through the risk categories, all of a sudden the potential maternal cardiovascular morbidity risk increases, and it can be anywhere as high as 10.5% in this group. Maybe more your unrepaired shunt, your repaired tetralogy of Fallot. We've got 240 patients in the country with tetralogy of Fallot in adulthood. So again, quite a high prevalence. And these patients typically will have right heart dysfunction, residual pulmonary regurgitation, your arrhythmias, and importantly your Turner's without aortopathy. And the reason I've asterisked that is when we think of Turner syndrome, we can't really apply the usual 40 millimeters, 45 millimeters, 50 millimeter cutoffs because they have a different body habitus, and we have to think a bit more clever about that. And we index their measurements to their BSA, and all of a sudden that small aorta is no longer so small. So it's important to remember that. Again, though, these patients, while they should be seen a little bit more frequently than the group 1 patients, they're still relatively low risk and can be delivered in their local hospital, normal vaginal delivery. Now we're getting into the hybrid group where you are starting to think about coming to the Royal, to the obstetric cardiology clinic. So, for example, your aortopathy syndrome that's in the mild to moderate range, your mild left ventricular cardiomyopathy that's stable from a symptomatic point of view, your hypertrophic cardiomyopathy. And again, we're approaching 20% maternal morbidity. These women should be delivered locally. They absolutely should not be advised to not get pregnant. They should get pregnant. But we like to hear about these patients and get them seen earlier and get them put into a program then of regular surveillance via echocardiography, BNP blood monitoring, and symptomatic review. And now we're getting into the higher risk groups. So group 3, and I'm sorry, this is quite an extensive overview of multiple pathology. I don't expect everybody to remember this, but we like that you'll see our letters. We will always try to refer to these risk categories because it automatically stratifies what you should and shouldn't do in a black and white format. Now you're getting into the patients that may struggle. Pregnancy is not contraindicated, but it is high risk. And you can see that mortality or maternal complications are anywhere as high as 30%. This is your severe aortic stenosis patients. If they're asymptomatic, if they're symptomatic, they should be advised against pregnancy or have an intervention before they get pregnant. Your moderate aortopathies, your peripartum cardiomyopathies who have resolved, whose LV has normalized and who are no longer symptomatic, and your unrepaired cyanotic congenital heart disease. Now, people hear Fontan and they hear unrepaired cyanotic congenital heart disease. Oh my God, it's such complex pathology, but actually the risk really isn't to mum in this setting. The risk is nearly always to the fetus. More often not, the circulating cardiovascular system just cannot support fetal development in the setting of chronic hypoxemia and the setting of univentricular physiology, and quite sadly, a lot of these women just don't make it to term. So actually, the complication rate from a maternal point of view can be lower than you would expect in that group simply because baby doesn't make it. Again, these patients should probably be seen at least every 1 to 2 months in our clinic. And then you have the highest risk group, and these are the patients that should not get pregnant. Okay, so they should not get pregnant. You could argue I should have jumped straight to the slide, but it's probably the more interesting of the lot. But these are your peripartum cardiomyopathy patients who have residual ventricular dysfunction, severe left ventricular dysfunction with symptoms. Your pulmonary arterial hypertensive patients, your significant aortopathies. Now, there's numerous aortopathies. I'll show you some data on this later. But we think of our Marfan's, our vascular aorta, Louis Dietz, and then our bicuspid aortopathy population. There are different cutoffs for each of those. I'm sure some people in the room have probably seen a vascular aorta patient come in with uterine rupture or significant postpartum hemorrhage. And it's a very traumatic thing, a very difficult thing to get under control. So risk here is extremely high. If a patient does become pregnant, we want to know about that very early. we will get them into our system, but they should be offered termination, and that is a European-wide recommendation in this setting, and they will come to the centre with us in the Royal, and they will be seen at least once every month, probably every fortnightly clinic with Michael Roberts and Inez Cook. This is the extensive pregnancy team. In Bristol, this was our MDT with this. So we had a clinic every fortnight, and we would do a 1-hour MDT beforehand, with the majority of these people being present, actually. We would talk about all of the impending pregnancies and try to formulate a delivery plan. You like to sometimes act like you know a little bit about, ergometrin, misoprostol, but actually it's quite nice being able to say over to the anaesthetic and a separate team regarding that, but we would come together and formulate plans. This is a very broad overview of cardiovascular disease and pregnancy. You can talk all day about this. Just some things that may change during pregnancy. It's normal to see ECG changes. The axis may change. T-wave changes may occur, and that's because we've changes in cardiac output, changes in volume, and even changes in cardiac axis. Echo, and this is my big bugbear, there are so many circulating emails, channels bypassing the aortic valve team in the Royal, whereby a patient has an echocardiogram in the setting of aortic stenosis that's previously been, the high end of moderate prior to pregnancy. They get pregnant. That's normal for our velocities and volumes through the valve to go up by 5 to 10%. The next thing you know, they jump into the severe category, but actually the valve still looks like it's opening well, and before you know it, somebody's been referred for a TAVI in pregnancy. You're just like, what? But that happens, and that's part of the reason why we really are trying to centralise our aortic valve screening program and pre-counselling program in pregnancy to the Royal. Just because I don't think it's fully appreciated, but it is normal to see changes in velocity through valves. It's normal to see chambers get a little bit bigger. But when you put all of that together, if you've got somebody with a cardiomyopathy, they may not tolerate that very well. They may or may not tolerate that well. Let's click through that. In terms of interventions in pregnancy, we'll keep this brief, but we know that they are safe. The optimal timing certainly is from the second trimester on if you're going to the cath lab. But if the patient has a STEMI, they should be treated as a STEMI. Okay, so they're fit to go to the cath lab. Thrombolysis does not cross the placenta, so it can be given as well. But in this day and age, that's such a rare thing to do for ST elevation myocardial infarction. And when we're doing the procedure in the cath lab, it's just being sensible. Have a narrow field of view, stay as far away as you can from the developing fetus. There's always been an age-old debate as to when should you offer an operation in pregnancy. When does mum do best? At what point does the fetus do worst? I think it makes a lot of sense that if you offer an operation in the first trimester, this is a large data set, again from the ROPAC registry of 386 women that underwent cardiac surgery during pregnancy. I think you have to assume the majority of first trimester is probably done very acutely. You're not going to offer an operation at that stage unless you really have to. And the truth be told, we often don't offer interventions during pregnancy. We often are confident seeing patients regularly and frequently and only pulling the trigger if we really have to. And I think that is safe. So you have to assume that all these operations are done in the acute setting. What you can see is that from a maternal mortality point of view, going early is, you've got a significant mortality, 12%. Fetal mortality, understandably, as high as 44%. But thereafter, it doesn't really seem to matter. The overall combined best time to go, if you can wait, is the third trimester. Okay. In terms of the timing of when to deliver and the mode of delivery, well, the recommendation is that women with cardiovascular disease, this is European recommendation, is that if you've cardiovascular disease, by the time you hit 40 weeks, you should be induced. And that's been shown to decrease the risk of emergency cesarean section by 12% and the risk of stillbirth by 50%. This won't be news to you guys. In terms of the delivery care plan, I'll show an example of one of our aortopathy care plans later on. That is very much lesion specific. We know that there is no maternal benefit for opting with routine cesarean section over normal vaginal delivery at the expense of low birth weight, leading an increased risk of venous thromboembolism and PE. However, there are certain cases whereby if a woman, typically the group 4 patient, is pregnant, whereby cesarean section should be considered. So your aggressive aortopathy, your pulmonary hypertension, heart failure with symptoms, you don't want to have pain, you don't want pushing, you don't want to have high blood pressure. You want to avoid all of those things and do it in a controlled setting. I thought that maybe we can't talk about every pathology, but maybe we can allude to 3, talk about 3 pathologies that all, I'm sure, we've encountered and all carry risks. So the first is the mechanical heart valve. Again, A lot of centres, and they should have, every centre should have a valve programme, I agree with that, but if you want to offer a good valve programme, you need to be contemporary, and it can't just be tissue valve for the childbearing female, mechanical valve if they don't want kids. That's not right, because there are so many other procedures out there now, okay? So many other procedures that can avoid either. But these are the things that are coming our way. We offer valve repair where possible in the aortic position, okay, in a woman of childbearing age. We can offer the Ross procedure, which is basically taking a native pulmonary valve, excising the diseased aortic valve, putting the pulmonary valve in that position, and then putting a homograft in the pulmonary position. That's got great outcomes. We've got the Osaki procedure, which has now come to the fore using the patient's own pericardial leaflets to create a new tricuspid aortic valve. And then these are other things that we do. And I know, for example, Sarah McNichol, you were with us quite a lot in the cath lab. You know that we do transcatheter mitral edge to edge. We do percutaneous pulmonary valve implantation. And there now are even transcatheter mitral valve replacements and transcatheter tricuspid valve replacements. So there are lots of options out there. But the caveat is, many of these valve lesions are tolerated very well during pregnancy. They're tolerated very well. They just need scrutinous follow-up. But the mechanical valve is something that makes us all nervous. We've got bleeding risk, we have thrombosis risk, we have teratogenic risk. And it's trying to balance the right strategy, and we have a good protocol that follows a nice protocol for what to do in this setting. We know that the risk of valve thrombosis, so the risk to mum from a valve thrombotic perspective, is lowest in warfarin. But once you get to unfractionated heparin, it can be as high as 33%. Low molecular heparin as high as 8%. And the reason that unfractionated heparin has been associated with valve thrombosis in the past is we used to say, take a peak follow any PGTs, and they were done poorly. And depending on what guideline you read, one will say aim for 2 times the upper limit of normal and 3 times, and that led to lots of crossover and poor compliance with intravenous unfractionated heparin and leading to thrombosis. Low molecular heparin has its problems as well. If you take anti-10A levels, and you set a peak target, well, the peak target being in range is great, but your trough might then dip down, especially in young, healthy, hyper-filtering women who have normal renal function, who filter the heparin out so quick. So these are the risks that the different agents carry. Now, undoubtedly, though, no surprise, fetal loss, teratogenesis is higher with warfarin. That is obviously well known, but what's maybe not as well known is the difference between high and low risk warfarin, okay? And if anybody's seen the ESC pathway, it's really quite nice and elegant. It breaks down what is considered to be high dose warfarin, and which carries highest risk. And we typically say, if you look at the top here, I don't think there's an arrow pointer in this, but if you look at the top, basically we define high dose warfarin as 5 milligrams or more. So if a patient's on 5 milligrams or more, if you look at first trimester, in yellow, that's class 2A. So that's a benefit to switch the patient in hospital and begin with to unfractionated, or actually, what's pragmatically much easier is low molecular heparin. That's what happens. You switch in the low molecular heparin if they're on more than 5 milligrams. And then once you get to the second trimester and that risk has been lowered from a teratogenic point of view, you then switch the patient back to warfarin, okay? So you can see the amber in the first trimester where it's advising continue warfarin. Well, that's class 2B. That's suggesting it might help, but actually probably doesn't, probably cause harm. And then as pregnancy progresses, then at 36 weeks we go back to heparin agent, and then within 36 hours of delivery, understandably, we go to intravenous unfractionated. Now, in women who are on less than 5 milligrams a day of warfarin, however, just continue it. Just continue it. That is the recommendation. This is where the evidence supports continuing with warfarin throughout until you get that 36-week period again, and you switch to your heparin agent. So, I don't know if that's what's happening. I would imagine any patient on warfarin or anticoagulation is coming through Michael and Inez, and that's what's happening in patients that we see, and it's certainly our pathway here in Belfast and it's the pathway in Bristol, but I'm not sure that globally this has been adopted, and you just find a lot of people just switch from warfarin at the start. The recommendation actually would be that you continue it for as long as you can, really. 3 final slides, if that's okay. I appreciate this is just a lot, but pulmonary arterial hypertension, you don't see it that frequently. A lot of these women don't make it the term, but for those that do, it has significant morbidity and mortality. How we define that? Well, the definition's been recently updated. It's a mean pulmonary arterial pressure invasively of greater than 20 millimeters mercury, with a low pulmonary wedge pressure less than 15, and pulmonary vascular resistance greater than 3. And mortality is up to 30% in this patient group, and we thus advise that they don't get pregnant and should offer should offer termination of pregnancy. The highest risk, of course, is around the time of delivery and afterwards due to those rapid changes in pulmonary vascular resistance. The most common cause of crisis failure, or cause of maternal death failure, is pulmonary arterial hypertensive crisis, and that can occur at any point after delivery. Of course, that increased PVR can do that, but actually, in fact, of all the drugs that these patients can be on, so you've got phosphodiesterase inhibitors, sildenafil, you've got your endothelial receptor antagonists such as bosentan, and you've got your prostacyclin analogues, and among some of the more specialised drugs, the only one that's really been studied in human beings and proven to be safe has been the phosphodiesterase inhibitors. So a lot of these patients have their very important medications withdrawn, and that is a problem. That is a problem. So it makes sense that they may have rebound pulmonary hypertension. And as I've already said, fetal death, decreased cardiac output, chronic hypoxemia. So it's a very real and very serious problem. Quite simply, pregnancy is ill-advised. You can see it you can see at the bottom of this ESC schemata that it's a class 3B, so it's red. They should not get pregnant. They should be counselled appropriately on that. If they do get pregnant, they should be referred to a pulmonary hypertensive and an expert pregnancy team. And the medications, while I could stand here and say what hasn't been studied in human beings, they don't get stopped until we've spoken to the pulmonary hypertensive team and the obstetric team, because there's a massive risk of rebound pulmonary hypertensive crisis to the mum. Finally, aortic diseases of pregnancy. Okay, I think this is the one that scares me the most, because this is the A&E disaster. This is the 3:00 in the morning aortic dissection, and it's probably one of the. Sorry, my microphone. Am I coming in out of range? Sorry. It's probably something that's historically been a little bit. It's pretty understood among all of us, really, in many ways, and we all think that, well, actually, patient delivers and they're safe, but they're not. It's that sort of 5, 6, 7 day period after delivery where you'll see the dissections happening, So the dissections class really occur late in this group. The most common aortopathy you're going to see is the bicuspid aortic valve. Okay, so it's a very common valve problem associated with aortopathy. However, it rarely leads to dissection in pregnancy. Okay, but compared to the other more syndromic forms of aortopathy, and the ESC guideline breaks this down really nicely. But it really talks about Marfan's, bicuspid disease, Lewy-Botts, Ehlers-Danlos loss, and Turner syndrome. And you can see the people that they really are concerned about. The Marfan greater than 45 millimeters, or 40 if they've a high-risk feature, so that's family risk of dissection, rapidly progressive aortopathy. Bicuspid greater than 50. Vascular Ehlers-Danlos, if you've got type 4 Ehlers-Danlos, you should be advised not to get pregnant. And then Turner's, that aortic severity index of greater than 25 millimeters per meter squared, because we know they are often short stature, and the same rules don't apply. Now, I worked with Stephanie Curtis in Bristol, so she was the pregnancy lead, and she, along with Lorna Swan, they certainly from a cardiac perspective would front up the aortopathy screening service in the UK. And they published a very elegant paper last year, showed that about 60% of dissections occur postnatally, and the median time of dissection was 6 days postpartum. So my recommendation is that if somebody has an aortopathy, is that they should stay in hospital for at least 5 to 7 days afterwards. They should have an echo done afterwards, and they should have very strict blood pressure control. And it's not just the changes in cardiac output, it's not just the changes in systemic vascular resistance that lead to dissection. It happens at a cellular level as well, so we see changes in the media of these large vessels. So there are numerous reasons why patients can dissect, and there are numerous reasons, therefore, why patients can dissect at normal aortic dimensions. And that's the thing. So a Marfan patient can still, so they have a very low threshold for keeping these patients in hospital. But the scary thing about this registry was that one thing was clear. About 75% of the women weren't aware they had an aortopathy. So in this group, pregnancy counselling is key. Now, in terms of delivery planning, this may look to be very extensive, it may look a wee bit heavy, but actually you can see here, for the aortopathies, the majority are recommended to start on a beta blocker. So classically get the patient through the first trimester and then get them on the beta blocker, or start it during the first trimester and just have very routine fetal screening. They should be echoed probably every 1 to 2 months, okay, to see how the aortic vasculature is changing, whether things are getting bigger or not. Epidurals, that makes sense, right? So probably, I don't know, practice varies, but really I think you're going to allow, everyone's going to get an epidural except think about Marfan patients, there's numerous reasons why they can't. You're going to allow about 2 hours of pushing. At that point, you've got to take over and help, and that's where I think they become active at that point. with our delivery. So this is an example. This was a care plan for a patient in Bristol. Okay, this patient had aortopathy, and this is where I think we should be. This is where we should be. I think every woman with cardiovascular disease should have a plan like this. So the first stage of labour, strict blood pressure control, less than 130/80. Labetalol, nifedipine, okay. Epidural for cardiac protection for the aortopathy patient. Then we get to the second stage. We give 2 hours for passive descent, and then it's forceps delivery with no maternal effort. Okay. The third stage, management of postpartum hemorrhage. We're going to avoid ergometrin-derived products. We know that it causes vasoconstriction, it causes increased SVR, so we're going to use misoprostol if we have to, oxytocin. Okay, they're the safer. They would be certainly the more safer drugs to go to. But I mean, personally, yes, we have, as cardiologists, we have knowledge of all of this, but actually it's coming together for you guys. It's coming together with the obstetric payment formulating this plan. But this is the gold standard, in my opinion. And then if you look at then after delivery, 4-hour blood pressure, nifedipine, labetalol, echo at 2 to 3 days, but staying in hospital for 7 days. And this patient's aorta wasn't that big. It was mildly dilated in the setting of warfarins. But I mean, this is the way, as you've seen, this is the way we should approach it, because the dissection risk is still so high at that point. Finally, I think this is my last slide. If a Marfan patient, for example, becomes pregnant, it is safe to do an MR or an MR angiogram during that pregnancy. Why? Well, they may have Harrington rods, which could get in your way if you're going to do anything. Or equally, dural ectasia, which is very common in this patient group, which makes an epidural challenging if not contraindicated. So it's just one thing that we always try to do if it hasn't been done previously. And I think that is the last slide. Yeah. So to summarise, cardiovascular disease, whether hypertensive or not, is a leading cause of morbidity and mortality. We do have a nice robust guideline, the ESC 2018 guideline, which covers the different risk categories for this patient group. We know any take-home message from this should be that those in group 4 should be advised against pregnancy and offered termination. We should be aware of different policies and protocols, for example, the aortopathy protocol and management of coagulation within pregnancy. And I think really overall, maybe not going to finish with what I've seen at the bottom, or what I'm saying at the bottom, I'm going to say that the management of this patient is critical upon us all coming together as a group. I'm not just thinking that it's one cardiologist, one obstetrician making the calls here. The delivery plan should be formulated by a group of experienced individuals, and that can be involving 10 different specialists, and that's the way it should be, and that's the way we hope to continue things in Northern Ireland. But thank you for listening.
Thank you very much, Paul. That was fascinating and terrifying, I think, as well. But it's very reassuring to know that your team's there, and I think Embrace reports how that need for that joint with patients of that degree of complexity, with that high risk of complications. Having a joined up experienced team is just critical. That sheet that you showed up leads nice our next week, because that is gold dust, I think, for anaesthetists on the board, particularly as registrars in the middle of the night. You're faced with a complex patient, having that laid out clear plan for complex patients. And the first place I've seen that done is actually our next speaker, Gary Benson, one of the consultant haematologists in Belfast City Hospital. I always remember as a registrar coming through night shifts where the haematology patients would come through and frantically leafing through the notes to find the purple sheet of paper where Dr. Benson laid out a really clear, explicit plan, just as you had there, for what to do with the patients. And it was the combination of relief and euphoria on finding that. Unfortunately, Dr. Benson isn't here with us today. He's given us a recording of his talk. As he's a consultant in haematology in the Belfast Trust. He's the director of the Haemophilia Centre, and according to his own Twitter bio, he has a passion for hemostasis, which I'm sure is shared by everybody in this room and anybody that works on a labour ward anyway. He's published over 91 times. He's a fabulous speaker. Bear in mind he's not here, so any questions for Dr. Benson? You have to be very careful about asking complex haematology questions of the rest of us. But if there's things to discuss, please put them on the slide. Okay. Like a short pause in the video getting started. Unfortunately, it'll just be Gary's voice that we hear. We'll not get to see him.
Hello, it's Gary Benson here. Apologies, I'm not there with you today, as I had hoped to have been. And apologies for having to pre-record the lecture for you. The downside to this is inability to answer any questions, and certainly from my perspective, the point of care coagulation is becoming an increasingly asked query that is coming in my direction, particularly in relation to obstetrics. So what I want to do is really to try to have a tour through point of care coagulation. Are we pushing it too much at this stage, or are we good to go? So as many of you will be aware, my background is with regards to haematology and bleeding and clotting, and haematologists who will undertake the combined haematology obstetric clinic at the Royal Maternity, which I do on a fortnightly basis on a Tuesday morning, in taking women who have high-risk bleeding background, or women with a background of active clotting or past clotting. We do know that globally hemorrhage and postpartum hemorrhage remains a significant risk, both of morbidity as well as, unfortunately, mortality in obstetric patients, and the most definitive manoeuvre that is undertaken will be that of the emergency hysterectomy. So a lot of focus has always been on this area. More recently, probably over the last number of years, there's been a lot of this discussion around fibrinogen itself. The role of fibrinogen in the routine coagulation screen, but also the specific targeting of the replacement of fibrinogen. Not just through cryoprecipitate or fresh frozen plasma, but actually the use of fibrinogen concentrate itself, which is a particular unique thing in the setting of an obstetric coagulopathy. We know that in normal pregnancy, the majority of the coagulation factors actually increase. So most of my young women who will come to me as carriers of haemophilia A, for example, if they start off with a low level of around 20 to 30% factor VIII, by the time they actually come to deliver, their factor VIII level will be well over 100, 150%. So this gain of function of clotting factors is largely to compensate and to reduce down the risk of bleeding, even in women with mild bleeding disorders. And fibrinogen is no different. Whenever they've looked at postpartum hemorrhage, they've actually found that most women who do tend to suffer postpartum hemorrhage at the time of their delivery will often have a fibrinogen at the lower end of the normal range. That's to say, in and around about 2. We don't routinely do coagulation screens before delivery. We don't need to. But certainly those women who do bleed tend to start off at a lower level, as opposed to those women who have physiologically increased their fibrinogen level to levels of around 5 or 6, which would be normal in pregnancy, but not in the non-pregnant patient. Yes, the fibrinogen levels and the clotting factors do increase our risk of venous thromboembolism, and we definitely see that, but the majority of the cases of postpartum hemorrhage are actually managed without having to give any specific clotting products outside of packed cells predominantly. And as I said, a low plasma fibrinogen level has been shown independently to increase the risk of progression to severe postpartum hemorrhage, and it's not often the platelet count. Like, we do a full blood count before delivery on all women, or as far as we can do. But actually the platelet count itself has never been shown, even with them with a low platelet count, as in between 30 to 50, doesn't actually increase their bleeding risk. It's predominantly fibrinogen. So what I want to try to do is to go through 3 specific areas. The first one is really point of care, unique to haematology. Then we'll go through major obstetric hemorrhage and its management, and we'll give an example of the changes that point of care have brought about through a single centre in the UK. Just for you to sort of have a visualization of what an algorithm would look like. There are many different ones. I am not promoting this one over and above another one. And then equally from your perspective, or your trust perspective, or what the next steps are going to be in relation to point of care. What I want to remind everybody is, as a haematologist, I am a laboratory clinician, so I'm actually trained in the pathology of blood. So all analyzers that are purchased and are run through the individual trusts are done so through the haematology consultant team. So we're there understanding the different nuances of the machines that are coming in to make sure that you get the results that you want from the machine. For the vast majority, particularly in haematology, we don't have a lot of point of care. There's a point of care hemoglobin or a HemaQ, and this has perhaps been more uniquely used within trusts within your own area of anaesthetic pre-assessment clinics, and largely as a rapid screening tool to see if anybody is particularly anemic. I often find this comes in vogue and out of vogue. Not that widely used, I don't believe, nowadays, but perhaps more so in individual hospitals where there is no on-site laboratory, where the transportation of samples seems to add additional time to the turnaround of the result. Perhaps one that we do know a lot more about is point-of-care INR. So you can, as well as patients, can purchase the machine themselves. It's about the size of the palm of your hand. They can do a finger prick rather than a venous sample, and they can monitor their warfarin through the INR, and they can also be trained to dose themselves. Or some patients will get an INR and then they'll phone their monitoring clinic, be that the Children's Pediatric Cardiology Clinic or an outpatient warfarin clinic. Slightly larger monitors are now available in primary care, and they will check the INR for patients in a more timely fashion. You'll be well versed in point of care with regards to blood gas analyzers and things like that, but with regards to haematology, they're probably the two main ones that we would most frequently be involved in. In order to get a point-of-care device or machine, there's application processes that you have to go through with regards to each of the trusts, and you have to sort of answer each of these questions. So very often, the first question is, why is the laboratory unable to fulfill or to meet your needs? So why do you feel that you need to get a different way to test a patient to get the results in your hand faster? They then rephrase the question and ask you then, well, if the laboratory can't fulfill your needs, have you engaged with the laboratory to fulfill the needs? So is it takes too long to get a result? Well, then can we enhance the delivery of samples? Can we fast-track samples through analyzers? Can we have a dedicated analyzer in the laboratory just for your patients to try to speed up the results in your hand? And unfortunately, the coagulation screen is a very difficult one to speed up the lab. Our turnaround time is around about 1 hour. But remember, whenever we talk about a turnaround time, that's whenever we actually get the sample. From your perspective, your turnaround time starts from whenever the sample leaves theatre. So the sample has to sit with us for 15 minutes to settle, and then it has to spin for 15 minutes, and then it goes on to the machine, and then you'll get the result then back after that. So it is very long, particularly in the setting of hemorrhage. You then ask, well, are there any standards of care to bring in the analyzer or the machine that you think that will answer and solve all of these challenges that you're facing? Thankfully, with regards to postpartum hemorrhage and point of care, there are innumerable standards now and algorithms now in place, both in the published literature but also with regards to colleagues in other trusts. The next bit, though, however, tends to be that little bit more of a challenge is the practical side of it. Because the point-of-care device is actually owned and operated by the service group who want it. So the laboratory do not fund it or pay for it or really have much in the way of support or oversight outside of training and quality assurance. So staff training, how many people are going to have to be trained in order to do it? So with that question, we need to know how often major hemorrhage, if that is the starting point, actually gets triggered within the group. So if we have X number of major hemorrhage declared in a year and we have Y staff, well, how often will a member of staff be confronted with massive hemorrhage in order to be familiar and competent to follow an algorithm, because a point-of-care device, you do the test, you interpret the test, and you manage the test. So you don't get a result and you phone somebody else with the result to tell them what it is. So the whole point is that you get it in your hand, and then you're best placed to manage it. I would certainly know that if you do ROTEM or a TEG point-of-care for coagulation, and then you phone haematology and ask them what to do with the R time or the XTEM result of 15 millimeters, and they will always ask you for the coag screen and the PT and the APTT, which is what they're trained in. Next question then is, well, where are you going to put the machine? So the machine is a little bit like a coffee machine, so it's not that much bigger than it. So where are you going to place it? So is it in anaesthetic recovery? Is it in theatre? And how many delivery theatres do you have? Do you want one per theatre? And then with regards to location, we then have to work out the IT means. So what's the connectivity of the analyzer? And given the challenges that postpartum hemorrhage have, majority, I would suspect that we would find them medical legally, is to make sure that the results that you get are collated and held centrally rather than getting bits of paper that can often become detached or lost. So how is it you want the results to be seen, let's say on ECR, on haematology? You want it to be apparent. I touched on staff training and the volume of massive hemorrhage you've had, so how often are you going to be using the test? So with regard to postpartum hemorrhage, the starting point is often whenever 1,500 mils of blood loss is expected, and therefore that is your starting point. So how often are staff going to be in that position to run the test and to interpret it? And then the final bit is really the impact elsewhere in the service. So staff have to be trained and take them out of service in order to get that done. But is there any extra impact? Well, I suppose the one bit with regards to this is less blood apparently is required to be transfused. So actually the impact on service elsewhere may be actually within the blood bank laboratory itself, in that there's less blood now being requested. Therefore, given our current constraints within Northern Ireland of our O negative and O positive supply, that would certainly be a good thing. But equally, if we're trying to get the result faster, are you wanting to give other treatment faster? Now, as I hinted at the earlier slide, this fibrinogen concentrate use, which is very topical at the minute, are you wanting, therefore, to get a result so that you can administer fibrinogen concentrate more promptly? So if you want to administer it more promptly, there's no point for it to be stuck in the blood bank. Therefore, all of a sudden, we're now getting an analyzer, and then we're needing some extra space to put some clotting factors. There's often a little bit of me with a wry smile at things whenever people come up with the latest analyzer, because a lot of the footwork with regards to these analyzers are largely driven, if we're entirely honest, by the pharmaceutical industry themselves, who have manufactured these machines. And of course, they will extol the virtues of having the ability to get their analyzer purchased and to be used. So we don't want to fall into the trap of the example of the Nutri-Ninja bullet, which will eventually find its way to the back of our cupboard, and we will very rarely, if ever, use it. So currently what we have are really two point-of-care devices. So the first one that's shown is the ROTEM. They're both done on the same technology, and here's the TEG. So they use real time with regards to getting the coagulation screen result back. So you put the sample in, you hit go, and then it will run. So depending on what's wrong with the coagulation of your patient, the test can run up to 20 to 30 minutes before the test run time is concluded. So it's not something that you get back within minutes. And so you have to get it started, and then you will interpret it as it runs its way. So the issue is we have two devices, so how would we ever have to make a decision between them? And I suppose that from a haematology laboratory side, if we had to try to decide between the two different machines, of which there's no reason why we're tied one into the other, cap piercing is certainly the most important thing. And during COVID, it was the one thing that actually made and broke the lab with regards to certain tests. So there are some tests in the laboratory whenever you send us the sample that we have to take the lid off the bottle. And we will have to pipette out aliquots of either plasma or serum or whatever we're testing, and then to put those into an analyzer. Given the risk of aerosolizing any sort of a virus, we now prefer not to undertake any of those tests. So we prefer to just use a bottle that you put into the analyzer, and then the analyzer itself will pierce the cap. Pipetting itself can be very difficult to standardize with regards to training, and given the fact that you'd have to take the lid off and put in a pipette to titrate out an aliquot of blood, there's risks of spills, contaminations and infection. And both of the devices will take a blue bottle, so you still have to do a coagulation bottle, which has to be filled appropriately. However, the Rotem will take it as the blue bottle, and you put the whole bottle in with the lid on, and it will pierce the cap and start the timer, as opposed to the TEG, which requires currently the cap to be removed and for you to pipette an aliquot of the blood out into the analyzer. So as we move forward, we'll refer more to the Rotem device as opposed to the TEG in relation to where we are currently. So this is what the Rotem device will look like. So you put the sample, the blue bottle in, pierce its cap, it hits go, and then you will get these different traces. So depending on what it is you look at, whether it's the X-TEM, which will look at the extrinsic pathway, which uses tissue factor, which is really your factor 7 dependent clotting. You have the FIB-TEM, which will give you a very rapid quantification of fibrinogen concentrate, and it's measured in millimeters, so it will go from the top to the bottom of the thickest part of your curve, and you'll get a result in millimeters. And then we also then have the APTEM. So there's lots of different applications. So for example, in cardiothoracic, there's an additional one that we use, which is a heparin sensitive channel, which allows us to reverse heparin. It's a little bit more unique for cardiac. So you can see what the normal clot looks like, and as we work our way down, we then get hyperfibrinolysis. So you make the clot, and the clot strength is reasonable, but then it tails off. So we all know about hyperfibrinolysis, which is very common in the gravid uterus after baby has been delivered. The uterus itself exudes hyperfibrinolytic proteins. So that type of a picture is not that unusual, so you'd often give tranexamic acid. And then you can see with the subsequent APTEM that there's complete reversal of the hyperfibrinolytic pathway after the tranexamic acid has been given. So again, one of the advantages of the Rotem is not just the fact that you get a result now, but actually you can intervene, give some treatment, and then repeat it, and then you can actually see the improvement after the intervention has happened. And then get down to fibrinogen deficiency. And as I said, the FIB-TEM is more sensitive for that. So the example that we have with regards to the FIB-TEM is 3 millimeters, and as it is less than the 10 millimeters, then that is highly suggestive of fibrinogen deficiency. And in the setting of postpartum hemorrhage, current algorithms would recommend the rapid replacement of fibrinogen concentrate in that setting. So you get that result back within 5 to 10 minutes, as opposed to still waiting for the portering service to come to collect the blue bottle to take it to the laboratory. Platelet count can be helpful, and we can look at it. Platelets aren't often, as I said at the start, that much of a key predictor in the setting of postpartum hemorrhage, but can be helpful. And then we have the alternative hypercoagulability, whereby there is a lot of activated clotting stuff going on, less that much of an issue. So we tend to look at pathways for abnormality, as opposed to knowing what the normal range is. So you will look at FIB-TEM whenever it's outside or less than 10 millimeters and react to that, as opposed to working out what the normal range is. This is one example, and this is from Australia. There's lots of different ways to look at it. I quite like this one. Just depends on how your brain works whenever you look at it. So this takes the abnormality of the ROTEM and then will translate it across. So FIB-10, your eye goes to less than 12 millimeters, diagnosis is a low fibrinogen, therefore your recommendation is cryoprecipitate or fibrinogen concentrate. And anywhere up to 6 grams of fibrinogen concentrate would be given. You would repeat the test after 10 minutes from the administration of what you've given, and then you can see that this has corrected. Often, if fibrinogen is being given, or indeed cryoprecipitate, tranexamic acid is generally given alongside it just to make sure you're not replacing fibrinogen only to have hyperfibrinolysis take it out immediately. The next one is the familiar one. Looks like one of those baby pepper bells. So it's hyperfibrinolysis. So you can see that there's an attempt to make a clot, but this rapidly dissolves. Options are your tranexamic acid as standard. Platelets then have an option whenever you look at it. There may be a representation of the reduction in the X-TEM, but that the FIB-10 is preserved, therefore we would suspect that the platelets may be an issue, therefore a unit of platelets would be recommended to be transfused. Again, at all times it's important to bear in mind that the starting point here is not all hemorrhage, but often it's postpartum hemorrhage of more than 1,500 mils as estimated at that time. Next one then can be clotting factors, and this can be a little bit controversial, I think, currently, but it really revolves around consideration of prothrombin complex concentrate. I think there's a big push now with point-of-care devices to try not to use the clotting factor transfusions of FFP, largely because there's been a bit of work done on what's called a dilutional coagulopathy, whereby the large volume of FFP that has to be given ends up providing more dilution to the current clotting factors that are present, and that in itself actually adds to the coagulopathy. So you can see there through the various options that we have of FFP, this group will use prothrombin X, ours will be Octaplex, and it's no different, it contains factor 2, 7, 9 and 10, and then how you would do it. And ultimately, once you get the abnormality on the left, you have your intervention in the middle, then you repeat it 10 minutes after intervention to look at the response. Amazing. If you think about doing this with a routine coagulation screen in postpartum hemorrhage, it takes an hour at least to get the result. By the time you infuse all the stuff that you need to do, and then repeat it, which will then take another hour, you're already sitting at 2 hours out before you're able to see any difference in a blood test, as opposed to 10 minutes that we have with regards to the ROTEM. So this is an example, and I stress an example, so please don't necessarily take down everything. They're all available just by typing in postpartum hemorrhage to Google Images, which is where I stole this one from, but I quite like it because it kind of shows the progression of thought and the changed algorithms that has happened over a number of years, and this takes Liverpool Women's Hospital. So this is done initially prior to the introduction of a ROTEM device. So you will have your 1,500 mils blood loss, call for help, and then you'll take your blood. You can see ROTEM is mentioned in it, but even though it's mentioned in it, it does not have any additional comment whatsoever in relation to the results that you actually get. So you call massive hemorrhage, and your massive hemorrhage pack is 4 packs of red cells, 4 FFP, and 1 donor platelet, and that's given as standard. It's then reassessed, and then if you need to, then the same thing gets repeated. So it's a very much formulaic approach in relation to the management of hemorrhage. There is one comment there to the right that says 2 packs of cryoprecipitate if fibrinogen less than 2 or as guided by the ROTEM, but there's no comment on ROTEM. And this was originally their first version back in 2011. This thing gets updated, and we can see it in July 2012. At this stage then, really the start is all appearing much the same, 1,500 units, 1,500 units, my goodness, 1,500 mils of blood lost, call for help, now Rotem appears, and Rotem is now in bold red. So if there's no Rotem, you go down the previous standard of 4 blood, 4 FFP and 1 platelet, whereas if you do have the Rotem pathway, it is 4 blood, 1 platelet, and then you'll follow Rotem directed results. Everything else is largely much the same, although do note that with regards to fibrinogen concentrate, now replace cryoprecipitate if the fibrinogen is less than 1.5 or as guided by the Rotem. So we're moved away from cryoprecipitate and now fibrinogen concentrate. So it makes comment then that if you have the Rotem, you don't give FFP, but you follow its pathway. So the pathway at that stage that was developed then will go down 4 units of 4 units of red cells, no FFP at this stage, and then you will run your XTEM and your FibTEM together, and then based on that you can see that your outcomes can be to give fibrinogen concentrate, to recheck in an hour if no ongoing bleeding at the time of doing it, or indeed that no products are required. My bit will always look for FibTEM, given all the evidence that we have. So FibTEM less than 7, give the concentrate. 7 to 12, high risk of bleeding, give the concentrate. 7 to 12, not bleeding, just check it again. So is it bottomed out at 7 to 12 on its way up, or is it 7 to 12 and on its way down? So it is helpful with regards to what to do. They'll also say then that the platelets are only considered to be administered in this example if the XTEM is low but the FibTEM is normal, or if you've given 10 units of blood. As I said, this is from back in 2012. It probably shows where a lot of us may be at with regards to the evolution of the Rotem. But I think currently anywhere up to 6 grams of fibrinogen would be considered appropriate to have available at the time, and that would be a better take on it. What's important though that with it, it's not just having an algorithm in place or actually having the machine to be able to do the test. So whenever we're actually administering something, we have to be able to give the hemostatic drug the right one and the right intervention. So it's not as if the only thing that's happening here is the Rotem. There's a lot of other manoeuvres ongoing in order to try to control the blood loss. And we have to be able to give things at the right dose, be that the tranexamic acid, be that the fibrinogen concentrate, or if prothrombin complex concentrate comes into it, make sure that we have the right dose, largely weight driven. We have to give it the right time and the right sequence. And the reason why FFP has now largely fallen off, particularly with Rotem devices, is that if you give your 4 to 6 grams of fibrinogen concentrate, and then you've already ordered your 4 FFP and then you give it, you end up coming back to where you started, because your FFP dilutes the fibrinogen concentrate that you've already given them. Therefore, the patient is no further forward with the fibrinogen in their body because it's been diluted. So it's almost some of the latter algorithms that we now have will certainly say that if you give fibrinogen concentrate, to really hold back on giving FFP, given the fact that giving FFP will actually worsen the situation with its dilution. So think about the order in which things are done and given, and to make sure that it's done maximally. Red cells have no particular role to play or interference with regards to the Rotem. I think significantly anemic patients we know, if you do a coagulation screen on them, their hematocrit is very low, so they have a higher plasma volume. So the volume of citrate in the blue bottle is often not enough to anticoagulate the larger plasma volume. So you will get an artifactual problem with your results. So profoundly anemic patients, even with a standard coagulation screen, you will get the anemia causing a problem, but that's to do with the citrate rather than a problem with the patient. Fibrinogen concentrate I've touched on, 4 to 6 grams seems to be the current standard. Tranexamic acid, I think it's now become almost a multivitamin for most procedures. Certainly with regards to this, at the setting it started bleeding, it seems to be the very first thing to go in. because if fibrinogen and hyperfibrinolysis has become an issue for the patient, the best thing to do is to try to take out that cascade. So you give a gram as a bolus and then maybe a gram considered as an infusion, almost like the CRASH 2 protocol. FFP and cryo certainly have their own role to play, but I think that they are increasingly less so with poorer evidence nowadays in this situation. But certainly current algorithms are driven by ROTEM. There's very little in the studies to give blindly 3-4 grams of fibrinogen concentrate. The earlier studies didn't necessarily show any particular benefit for that, but predominantly those whenever the ROTEM was used and the reduction in the FIB-10 result. So within the Belfast Trust then we had undertaken, there was a lot of interest with regards to multiple, I hate the word stakeholder, but lots of different service groups all came together at once and to raise their preference with regards to having a ROTEM. Cardiac theatre was the first to go, largely because their TEG machine that they had was on its last legs and really had to be replaced. The reason why we all got together is sometimes the safety in numbers makes training easier, but also the more machines that you get, then the better deal you can get from the company. The commonest way to get the machine is a reagent rental. So that's to say, the machine itself technically on paper is free, but what you pay for is each time that you do the test. With the test kit, again, entirely billed through service group and not through the laboratory. So cardiac theatre is up and running. Royal Maternity have a machine and an agreed algorithm already in place, and we also have placed 6 grams of fibrinogen concentrate alongside the machine. So this allows that if you actually do find the FIB-10 to be significantly reduced and the algorithm says to give fibrinogen concentrate, that you can give it straight away, that there is no delay in its administration. There's a bit of faffing in making fibrinogen concentrate. It's not a very easy dissolvable thing. But either way, there is 6 grams given, and then whenever that is used and it gets replaced through blood bank, it's the reissuing is then used against the individual who received the 6 grams. The Haematology Specialty Laboratory, where I work, and which covers the specialty investigations for Northern Ireland with regards to coagulation, we have a machine. Largely there, I think, just for information and just for us to have our own experience with regards to using it. But the majority is not of a diagnostic value of using the ROTEM, but rather in the setting of bleeding. And there's currently ongoing rollout with regards to the Royal Theatre as well as the City Hospital Theatre staff in having the ROTEM. But as stipulated there, the only place currently where the fibrinogen concentrate is available alongside the machine is at Royal Maternity. So my conclusion is that I do fully believe that this is not the latest Nutri-Ninja bullet to be hidden in a couple of months at the back of a cupboard, particularly in the setting of obstetric hemorrhage, not that bold away in other settings, if I'm perfectly honest with you, but it's well established in postpartum hemorrhage that the way into doing it, so how many tests would you have to do, look at your figures for estimated blood loss of 1,500 mils. Fibrinogen concentrate appears to have an exceptionally strong role with regards to postpartum hemorrhage and within this area. Therefore, I think that if we do go down the route of ROTEM within your own areas for postpartum hemorrhage, I do think that there's a very strong role for your blood bank laboratory to support you in having fibrinogen concentrate there and on standby. Otherwise, really, what's the point of doing the coagulation screen more rapidly through the ROTEM if we're still having to stand and wait for product, which is clotting factor concentrate, to arrive. All blood banks can buy in their own fibrinogen concentrate. It is not stocked and stored centrally at the Royal to be sent out as a distributor. So business cases may have to be done if you don't routinely hold it on site. And also, ultimately, you just have to develop your own guidelines with regards to how you're going to introduce it, what visually looks and makes sense to you. Is it a flowing algorithm with arrows? Is it more abnormal FID-10, X-10 results and how they get interpreted, involving your own haematology team or you're an interested haematologist. I'm an exceptionally interested haematologist in this, and validate its performance with regards to your use of it. And always to make sure that probably after the first couple of times that you do it, you'd always want to have some element of a debrief to see what worked well, how it helped you, and to make sure that everything went according to plan. So thanks very much for your time, and apologies that my time hasn't allowed me to be there with you. It's certainly a meeting that I've always enjoyed very much, coming along and catching up with everybody. If there do happen to be any questions, I'm very happy to have these emailed through. Very happy to type to myself for business again to come back and update ourselves. But certainly we'll look forward to working along with you in trying to have these established regionally if you are particularly interested in taking these further forward. So thank you very much.
Unfortunately, he really wanted to be here, but he couldn't make it. So his topic has been a particular interest to us this year during my fellowship in RMH, and we thankfully, after all these years of trying, have got our road time machine. So that was very useful. So hopefully all the other trusts won't be far behind, and like I said, is a very important topic. So moving on then to the questions. Thank you for anybody who's got questions in the Slido. So if we invite our speakers to come back up.
So we've had loads of questions come in, but we're also conscious that lunch is on the horizon as well, so we're going to pick up a few. So apologies we don't get all the questions to our speakers, but there might be an opportunity afterwards to have a quick chat over lunch. Several questions coming through from Neil, interest in the technology, and I suppose one of the big questions is what do we do as an anaesthetist with some of this, the wearable tech that comes in the theatre? And I suppose, is there a plan for a unified Northern Ireland-wide protocol or guidance on it? I suspect different trusts are doing different things.
Yeah, this technology is part of people's identities now. It's something that they won't surrender quickly. Their insulin pump maintains their life on an hour-by-hour basis, so there's no way they're going to surrender it. If it was a surprise to you, you need to take that off. The key thing there is preparation. Most people know they're pregnant before they come into the obstetric room to deliver, although I have to say that's not always the case. Yeah, I know. So the key thing there is preparation. There are limits to how far someone can manage their own care whenever, whether it's a planned delivery or an emergency delivery. And the backstop is if they're not going to be there to do it, if they can't exercise physical and cognitive control over what's happening, then they need to surrender that over. And as I said earlier, that actually can be a relief to the person. Well, what happens? Could they get complete panic that they lose control? I've seen people burst into tears when you come around the corner in a surgical ward because the control of their diabetes is taken away from them. And whenever they come around the corner, they think they're going to solve all this problem. And actually, what settles them is that there are controlled ways to do this, that there are tried and tested algorithms and protocols from which we can take that over and keep them safe when they're not competent to look after themselves. So the key thing there is preparation and communication beforehand by their diabetes team, so that they can then feel, with a feeling of confidence, know that whenever you come to them, that you're coming with a tried and tested and safe protocol that will carry them through until they're able to take it back on again.
Thank you very much.
Yeah, great. And then there's a question for Dr. Brennan here. There's a lot of obviously DGH people here as well. So the question is, should local cardiology teams and DGHs be involved in the non-tertiary cases?
Yeah, I think so. I mean, and that sometimes been blocked a little bit. Not blocked the wrong word. Michael and Inez are very, and then the Royal, Dr. Cook and Dr. Roberts are very, I suppose, receiving of all referrals, and we'll see just about anybody, and that's great and it's brilliant, but sometimes it's not maybe always necessary, and we'll contend that we should work together, both in Belfast and then the local hospitals, to try and better triage and filter who gets seen in their unit.
And just on that, there was a question, is there like a contact? Would you be happy to, the team in the Royal, be happy to take the referrals through from the district generals?
Yeah. So typically you either get a letter to the Dr. Cook, or even just to the obstetric cardiology clinic, and the letter will come through. I know Dr. Roberts, our consultant colleague, will take the referrals. I'm more than happy that emails or letters come my way, and even if I'm not going to be the person that sees in the clinic, because it's still largely Dr. Roberts, I will coordinate it thereafter, so I'm more than happy to be part of that.
There seems to be an increase in numbers of diabetic patients generally coming through our services. Do you anticipate that there's obviously difficulties accessing some of the new pumps and technology? Do you anticipate that coming in? Can we expect to see more people coming through, particularly with these closed-loop systems, in the coming year or so?
Yeah, the major barrier is funding for continuous glucose monitors. The intermittent or interstitial glucose monitor, the flash glucose monitor, has been funded for years, and we've been very avid uptakers of it. But the real integration comes with the continuous glucose monitors, and they're sparingly funded. As I said, they're funded for within pregnancy for women with type 1, but nobody's going to start doing a closed algorithm during pregnancy. I've only ever started an insulin pump once during pregnancy, and I don't think I'll ever do it again. As a gauge to how frequently these things are used, in Western Trust we have about 1,600 people living with type 1, and just under 10% of those are on insulin pumps. So that's about 120, 140, I think, is the total. And of those, only 3 people are using a hybrid closed-loop system, and that's a DIY system with third-party algorithms. And all three of those are not in childbearing years. That's any comfort to you. But it will become more common. The CAM APS system is the most likely one because it's approved. There is guidance published last month, draft NICE guidance, for use of automated pancreas systems to come into play. I think there's one little trial in antenatal care for the closed-loop systems with good results. But again, it's a very small study because of the very small numbers of people using it at the moment. But if this CGM and the closed-loop systems are approved in NICE, across Northern Ireland, it'll be a while before they're approved here. But the clamour is huge for this. Will it change things a terrible lot when it comes to delivery? We may get more people asking for what we would call pump-on delivery. And as long as the person, in an elective cesarean section where there are no other comorbidities and everything's going nice and smooth, then believe me, I know the difference between what it feels like to be with someone in an emergency and elective delivery and what difference it makes. But in that kind of scenario, the pump on, the period of fasting is insignificant or basically irrelevant. With the team well aware of what the device is, where it is, how it can be cared for during it, there's no reason why that can't continue. And by far, that's probably the most stable thing. So there's no reason why if a pump, you can do that with a smart pump that doesn't have an integrated algorithm. There's no reason why an automated algorithm can't do that as well. Because effectively, it takes diabetes out of the equation at all. Because unless you pull the pump off, it doesn't make any difference. They're just a woman having a delivery.
I think that actually answers a number of questions that came up on this side. We covered them all. But thank you so much to our 3 speakers, but our 2 especially that are here today. There's such advances in both those fields. It's very difficult to keep abreast of all the change. So it's terrific to get such an update from 2 expert speakers. So if we ask everybody to put our hands together for I think if there's others, we'll call our session to halt there. There's lunch next door if we go out the doors and turn right. And if we can spend a bit of time looking, there's a TV screen with our posters that are there, having a look at those while we're queuing up and waiting for lunch. But thank you all, and thank you again, our speakers.